wasn't accurate in my actuarial prediction of risk. And so capitation, we weren't ready for. We went from Wild West fee-for-service to an initial form of bundled payment called DRG, stands for Diagnostic Related Group, based on the prospective payment system, which I won't bore you with. Then we went to capitation, and we weren't ready. So we moved away from capitation. Now we're trying to insert bundled payment. And what bundled payment is kind of like pre-capitation. Instead of me going out of business if too many of you get heart attacks, everyone in the community could have a heart attack, and that doesn't knock the provider out of business because I'll get paid the same amount of money for every heart attack. So it's like illness-based care, episodic-based care. And so initially the bundled payment is for hospitals and physicians. The way they get paid now is if you have a heart attack and you get seen in the hospital by a bunch of different physicians, each one of those bills differently and the hospital bills separately. So there'll be what's called an ACE, an acute care episode for heart attack, where we will get paid one set of money, and it's up to the hospitals and the docs to figure out how to split that. So that eliminates incidence risk. And now what it says basically is you've got to figure out a way of reorganizing yourselves to take care of the heart attacks for less than the amount of money that you're getting paid, or for break even, or for more. We don't care, but if you do it for more, you go out of business. If you do it for break even, it's going to be hard for you to stay in business. You've got to figure out a way for doing it less. And don't think that you can fudge and do it for less and provide bad quality care, because if you do, your bad quality statistics will become apparent on the other side, because we're going to release that to the public. We've got you boxed in. You've got to pull costs out while getting quality better. And if all you do is pull costs out and the quality doesn't get better, you're going to get nailed. And if you make quality really good and that drives your costs through the roof, you're going to get nailed. You've got to pull costs out and you've got to make quality better. All right? And that's what this is going to drive. And the reason that they're focusing on this is because all the research shows that's got the greatest potential for what the phrase you hear is called bending the cost curve. Taking this cost curve growth that looks like this and not turning it into a negative, just having it look like this. No one's saying make it look like this. No one's saying make it look like this. We're saying take it from here to here. And that'll buy us a few extra years, before the economy collapses. And that's the struggle, is just to get it from here to here. And watch all the gnashing of teeth and all the grief that just getting it from here to here causes in this nation. It's going to be incredibly difficult. So that's just a quick primer on bundled payments. Now, to deal with a bundled payment, you then have to have a different, let me just go through this quickly. Here's the big issue. It's as I said, cost reduction is the key. There's a fee splitting issue and so on, but you can only split money with the docs if you save money, all right? So there are antitrust and Stark issues and so on. Physicians cannot be incentivized to ration care. They can't be incentivized to deny care. They can only be incentivized to get more efficient. And that means standardized protocols, elimination of variation, which is one of the drivers of inefficiency in the system. And what it also means is we can't have the traditional relationship that for years we've had, where you have independent docs spending the hospital's money and the hospital has no control over the independent docs. And so now is this notion of what you've been reading about accountable care organizations. And this is in the law for Medicare, and it's now going to spread to private pay, where hospitals and physicians will come together and create new organizations to be accountable for the defined population to receive bundled payment. And so the easy part is creating the organization. The hard part is deciding how you're going to split the money up. So for example, let's say, how would you do this? Let's say I give you a bundled payment for knee replacement. I'm going to give you one set fee for knee replacement. And who does knee replacement? Well, the hospital's involved, the orthopedic surgeon's involved, rehab is involved. How are you going to split the money up? Okay? Now, the way we do it now is we say, well, I want the most of it. If I'm the orthopedic surgeon, I want the most. And if I'm the hospital, I say, I should get the most. And if we sit down and try to figure it out, it's a zero-sum negotiation. I'll say, well, the only way I can get more money is by taking it out of your pocket, so give me more. Under an accountable care model, if you do that, everyone loses. The theory behind it is that those three groups have to sit down and say, what's in the best interest of the patient? How should we organize our services so the patients get the best knee replacements at the lowest costs, spend the least amount of time in the hospital, and return to work and life as quickly as possible? And that's easy to say, but it's very difficult to do. And that's what accountable care organizations are designed to do. And to do it involves a significant cultural transformation, huge cultural transformation. It's easy to take the check. It's easy to move boxes around on a sheet of paper and create these. The great challenge is making them work. And if they don't work, then you're going to start seeing organizations going out of business. So this is what you're reading in the paper quite a bit, is this issue of accountable care organizations. I talked to you about the readmits, so let me just run ahead very quickly. Also, what we're seeing is a massive focus on holding boards accountable for quality of care. There's something in the federal law called the False Claims Act, which was passed during the Civil War, which makes it illegal to file a false claim against the federal government. And anytime you submit a Medicare claim or a Medicaid claim, you're submitting a claim to the government. And so for years, people would it was called upcoding. If I had a really bad respiratory infection, you might code it as a pneumonia, you get paid more. There was a hospital in Redding, California, that was very famous for doing this. They did heart surgeries and catheterizations on anyone who walked in the door, literally. And they were accused of not having criteria for doing that. And that was not fair. They did have criteria. The criteria was, do you have a heart? You know, and if the answer was yes, then you should have heart surgery or a catheterization. And the government got very aggressive at cracking down for fraud, okay? Now what they're saying is, to hold boards accountable, there's more to fraud than just lying on a bill. If you treat a Medicare patient and you code it correctly and you bill correctly, but you didn't provide good quality care to that patient and you submit the bill, that's fraud. And so now what they're saying is we're going to hold boards accountable for their job of overseeing quality in a way we've never done before. And here's an example. This is an actual visual used by the Department of Justice to train their attorneys to prosecute hospitals under quality fraud. And where's the visual? I had it somewhere. Here we go. You know, has there been a systemic failure to, to fix quality issues? Have you filed false reports? But look at number 3. Has the organization profited from ignoring poor quality or providers of poor quality? And we've seen many hospitals do this. The board would say, well, gee, Dr. Orlikoff's not a very good doctor, but he's a big admitter or he makes lots of money. So we'll look the other way that he's not a very good provider. And now the government's saying you can't do that anymore, and if you do, we're going to nail you. And here's an example of one where they did this just last year in Georgia, a hospital that set up a new cardiac cath lab, and there was one physician who wasn't very good, lots of redos, lots of complications. The nurses knew it, the physicians wouldn't refer to this patient, but he was a big moneymaker because he was a very high volume doc. And when he came up to the board to have his privileges renewed, the board renewed his privileges. And it resulted in 1 patient dying and 3 patients being injured. That's a garden variety case. I mean, we've seen far worse cases, 30 patients killed, 17 patients killed. So 1 patient dying and a couple being injured. It happens everywhere. And the government came and said, ooh, you're out of business. And look at remember how I referred to the notion of demonization? Look at the quote of the Assistant Attorney General. We are committed to bringing to justice those who put profits ahead of patient health and safety. See, that's what I mean by demonization. So we can eliminate capacity, we can force you to get more efficient. You either get better or you go away. Either way, the costs go down. We're the good guys, healthcare is the bad guys. And that's what we're seeing happen. Now, there's a reason that they can do this, and that's because, you getting all this? That's because healthcare is horribly dangerous. Hospitals are the 4th leading cause of death in the United States. And many people don't believe that, but the data is very clear. We've had data starting in California in 1976 with the California Medical Insurance Feasibility Study. The big study was probably something you're familiar with, was in 1999. The Institute of Medicine released a study called To Err is Human, where they estimated that hospitals killed between 44,000 and 98,000 patients every year. And we don't like to use that word kill. Well, what does it mean? It means had they not come to the hospital, they would not have died. So we killed them. And what was the response to that? Oh, I don't believe the data, we're not going to change. And nothing happened. And we've got data that says, how have things changed since that groundbreaking study came out? And the answer is not at all. So look who's doing the studies now. And this one just came out in November of 2010. And it was based on looking at every hospitalized Medicare patient in this country in the month of October 2008. But look who did the study. It was the Office of the Inspector General. So now who's looking at safety and quality? It's the federal government enforcement arm. And here's what they found. Everyone who said that the IOM study was incorrect, they were right. We don't kill between 44,000 and 98,000 patients every year. We kill about 200,000 patients every year. I'm very serious about that. So what their study showed was 1 out of every 7 Medicare patients who was hospitalized was injured. Preventable injury caused by the healthcare system. So what I want you to understand is we have an outrageously expensive healthcare system and a really bad one in terms of quality and safety, and reliability. All right? And I won't do it here, but oftentimes when I'm speaking to large groups, I'll say, how many of you in this room have a loved one or a friend who's been injured in a hospital? And the hands all go flying up. So you multiply that times 300 million and you see the system that we have. So 1 out of every 7 Medicare patients was injured, and 1.5% of hospitalized Medicare patients, their death was directly attributable to preventable injury. And so we killed about 15,000. Of all the harm, about 44% was preventable. And in October 2008, 15,000 Medicare patients were killed because of preventable injury in hospitals. So if you annualize that, that's 180,000 Medicare patients. That doesn't count Medicare patients, which is why we're very confident in saying that hospitals kill over 200,000 patients a year. So this is going to be used both to get the public on the side of the transformation, and also to drive the notion of transparency and to drive the notion of we can't maintain the status quo. Why should we bankrupt the nation so that hospitals can kill patients and provide disintegrated, disorganized care, which nobody likes? When I'm flying on a plane and someone wants to start a conversation and says, what do you do? I've learned the hard way not to say I work in hospitals. Because no one ever says, oh, God bless you, you're doing the Lord's work. I was just in the hospital last week, or my mother was in the hospital. It was a wonderful experience. Everyone was so nice. They took great care of me. They explained everything. And the bill, how do you do it so cheaply? It's just amazing to me. No one ever says that, when people look at me, they say, what do you do for a living? I just make something up. What do I want to be today? Because I don't want to hear it for 4 hours on a plane. I don't want to hear about what happened to Grandma, because everyone's got a story and none of them are happy. Everyone's really ticked off. Okay, so you multiply that time. So wonderful. We treat you bad. We injure you. We lie to you, and we're bankrupting the nation. Who asks for anything more? And so that's why it's got to change, and that's why it's going to be driven. Now the hard part is, just to emphasize this to you, why I'm so confident in this data is we've also done other studies which showed we don't even pick up the extent of the injury. This was a study that looked at surgical cases, about 854 patients in 11 hospitals, and found that about 14.6% of them were injured, had a surgical adverse event. And 44% of these caused a readmission or caused an increase in the length of stay. But what's most significant, about 8.7% required life-saving intervention or caused the death, was that the vast majority of these events had not been detected by the traditional mechanisms of detecting injury. So most hospitals don't know how bad they are. We're not picking it up. But when you really come up with highly sophisticated, sensitive screening mechanisms, you really start seeing the extent of the injury. And so it's very, very problematic. So it's going to be easy for the government or the market to leverage this against hospitals. Why should we pay you for injuring patients? Why should we pay you for providing poor quality care? Do it right or go out of business. Do it right or be subsumed by a larger system. Pure and simple. And so that's a lot of what's being driven. So that raises a couple of interesting questions, and that then segues us into the discussion on governance. So before I do that, let me tell you this. The interesting thing is we know how to do it better. We really, really, really know how to do it better. This is data from Holland, where they went into Holland and took a look at the best hospitals, not the average hospitals, not the worst hospitals, the best hospitals. And by implementing an integrated surgical safety checklist, so that they use checklists before patients went into surgery, while they were in surgery, after surgery, they were able to reduce the mortality rate by 50%. And these were in the best hospitals. So imagine what we could do in the average hospitals or the worst hospitals. So just tremendous opportunity for improvement. And this is also something that's important to understand, is the whole issue of quality, safety, and cost is very counterintuitive. Most of us tend to believe that good quality care means expensive care. That good quality care means do more rather than less. So, could everyone in the audience please turn your cell phones off, because apparently it's causing some problems in the recordings. So turn them off, please. I said please. Please. She said please. I'm being more aggressive. Thank you. And I was thinking my cell phone's off. I was just about to make the most important point of the whole presentation, and it's gone now. That's okay here. That's all right. No problem. Okay. Gone. No, it is. We thought that the relationship between cost and quality was good quality means higher cost. More is better, right? Isn't it? And it turns out that's not true. It turns out from leading organizations in the country that are really doing it right, that the best quality comes at the most efficient use of resources. So for example, at the Virginia Mason Health System in Seattle, where I'm a board member, we're very committed to using what we call the Virginia Mason production system based on lean. And we've been doing this for 10 years, and there's never been a process we've looked at that we can't pull 50% of the cost out and improve the quality. It's really quite fascinating. So there have been enough organizations doing this and using different models that we know it can be done, but it's counterintuitive. Oftentimes the best quality comes by not doing something, or by doing only one thing instead of three things, and by doing it right the first time. And so figuring out ways to do this throughout the healthcare system, we've got wonderful potential, but the problem is it's going to be very, very challenging doing all this. Just pulling out the cost, pulling out the risk, figuring out ways of doing this more efficiently. And one of the things that then segues us into the next discussion, which is the issue of governance, is all of these issues require significant changes in the leadership of our organizations, in executive leadership, in physician leadership, and in governance, in boards of directors. And boards used to be sleepy, sleepy little creatures that weren't held accountable, that didn't have any real authority. And now we actually are able to measure and correlate board function to the success of the organization. There have been studies which have actually correlated how a hospital board functions to the mortality rate in the hospital. And that when a board really engages in quality and manifests certain characteristics, the mortality rate in the hospital goes down. So much more focus on governance than we've been before. But before we jump into that, let's finish this because I've gone through it very quickly, and then we'll open it up for a few questions. So the fundamental conclusion is, number one, the status quo is not an option. Things aren't going to be the same. Even if health reform gets repealed, it's never going to be the same. All of these forces still stay in play. And it's not an option for healthcare as a whole, nor is it an option for governance and our boards and the way we govern hospitals. And here's some of the big picture questions that people are facing around the country. Can we go it alone? Do we have enough size and scale that we can go it alone? Now, for a standalone hospital the size of that isn't a safety net hospital with some interesting waivers, you might have a very different answer than you would have for you. But what we're finding is the whole notion of the independent, free-range, standalone hospitals is going away. Most hospitals in this country today, over 65%, are part of systems. So the notion of the standalone, and Monterey is very unique, and it's because I think your 4 hospitals are all kind of basically standalone. I know Community Hospital of Monterey Peninsula is a standalone hospital and so on. So that's one question. Can we make it alone? And if so, how? And that then raises the second question is, how are we going to integrate and interact with our physicians differently so that everyone can provide the same care? And I mentioned this quickly, but it's worthy of another mention. What's one of the reasons we see such variation in cost and quality? It's because physicians behave very differently from one another. And here's a classic test. Suppose I had 10 patients who had the same illness and had the same severity of illness, and I brought them to 10 different members of the medical staff at Natividad. Would those physicians treat those 10 patients the same way? Or would they treat them differently? And the answer is, in most hospitals, they treat them completely differently. In the hospitals that have the highest quality and the lowest cost, they treat them all the same, because there are protocols and standards, and they have to follow the protocols. And many physicians resist this. They go, you just want us to be robots. Medicine's not, you can't do that. Medicine's an art and a science. Well, that's really interesting. It's not art and science. It's science, and where there is no science, then it's art. And 50% of medicine has no science behind it. 50% of what we do in the United States is not based on science. It's based on history and custom, and someone tried it this way 60 years ago and said they liked it, so I'll do it that way. Or it's based on, I tried this with a patient once, or I had a patient 20 years ago and I'm never going to do that again. That's how, and we're bankrupting the nation based on that. So where there's no science, fine. Okay, but where there's science, that's where you want protocols. That's where you want very, very clear protocols we have to follow. And the docs go, oh, I don't want to do that. Well, think about it. That's like a pilot saying, you mean I got to follow a checklist? You mean I got to put the landing gear down every time? Yeah, every time. Yeah, every time. Yeah, every single time. Okay, sorry about that. And if you don't like that, don't be a pilot. Okay, pure and simple. And so, and where it gets interesting is where you see combination of art and science. I cannot standardize the skill of a surgeon's fingers, but I can standardize that they discontinue antibiotics 24 hours after surgery, and that's a rule. Because it's very counterintuitive. If you want to prevent infections, doesn't it make more sense to have the patients on antibiotics for 3 or 4 days after surgery? No. The research is real clear, that there's an optimum period for the patient to be on antibiotics postoperatively, and unless they have evidence of infection, you discontinue antibiotics, and that's called a standing order. And in some hospitals, the docs have no problem with that. And in other hospitals, the docs go crazy because you're corrupting the individual prerogative of the physician. And that's one of the big challenges that we've had in the American healthcare system, is the balance between autonomy and accountability. And for years, autonomy has won. And now what you're going to see happen is slowly, painfully, accountability is going to win at the expense of autonomy. All right? And that's really important. And that's why when you take a look at the best systems, they've dealt with this issue. So for example, in Mayo Clinic, if the Mayo Clinic leaders get together and decide starting on Monday morning, we're going to do it this way, we're changing the protocol. And 5 Mayo docs say, I'm not going to do that. What happens on Tuesday? Yeah, they're not Mayo docs anymore. You can do it however you want, but you either do it this way or you don't do it here. And that's one of the big battles that's being fought around the country, especially in communities where you have independent medical staffs and high degrees of variation in the medical staff structures. And the culture of medicine, which was what anthropologists refer to as an expert culture, which sounds like a good thing, but it's not. In an expert culture of the medical staff, no individual is empowered to say yes, but every individual is empowered to say no. So there's an old joke. Let's say there are 100 docs on a medical staff, and they vote on something. There's an election, and the vote is 99-1. What's that called? A tie. All right. Because medical staffs have been culturally organized to protect the autonomy of the physicians. And so, if you have a bell-shaped curve distribution, and you've got leaders here, and then the average, and then the laggards, who has the most power in the average medical staff? The laggards. It's like you have a convoy. You're trying to get a convoy of ships across the ocean, and you've agreed to only go at the top speed of the slowest ship. Everyone's going to be held back based on, and if the ship wants to stop, and take a couple days off, the whole convoy has to stop. That's the way we've done that. Why? Because that generated inefficiency. Why was inefficiency good? Because that generated profitability. And now we're going to have to move away from that. And that's one of the big battles that's going to be fought, is changing the medical staff culture. And I gave you one example. Let me give you an actual example. Let's say you have 10 docs in a department, and they're debating. Let's say they're orthopedic surgeons. And each orthopedic surgeon does a knee replacement surgery, but they each like to do it differently. They use different bone sets, they use different prostheses, they use different preoperative protocols, different postoperative protocols. They all do it differently. And so what does that mean? That means when the charge nurse looks at the OR schedule and says, oh, there's a knee replacement scheduled for Monday morning at 9 a.m. They don't think this is how we do a knee replacement at Natividad. They think, oh, it's 9 a.m. and it's Dr. Orlikoff, and it's April. Oh, okay, that means he likes to do it this way. So instead of having one way of doing something, you probably have 30 or 40 different ways of doing the same thing, which magnifies cost inefficiency, magnifies poor quality, and magnifies the potential for iatrogenic injury. And the organizations that really do these things well have one way of doing it, one. Okay? And so, but now imagine you go into a medical staff department and go to these 10 orthopods and say, we want you to come up with one way of doing a knee replacement. And they honestly engage and debate and look at the literature, and they pick a bone set and they pick a protocol, and then they vote on it, and the vote is 7-3. What does that mean? Now, outside the medical staff, what would that mean to most of us in this room? It would mean a decision has been made, and we got to do it that way. In the medical staff, average medical staff department, that means either A, no decision has been made, or B, the 7 of you who voted for it, you can do that, but if I voted against it, I don't have to. And so instilling what non-physicians regard as basic tenets of leadership, majority rule, debate, then decide, is opposed to how we do it in most medical staffs, decide, then debate. The big debate begins after a decision has been made, is going to require significant change. And why do I take the time to tell you this is because you can't do that unless you have really grounded boards, really focused boards, who are willing to be the bad guy, who are willing to kind of push and cajole and hold the medical staffs accountable. And for years, the boards were hostages of medical staffs. Or the docs would threaten the boards, and the boards would back away. You're not a doctor, you don't know anything about this stuff. And the boards would kind of back away. So that's always that's also another way of kind of giving you an indication of how governance is going to change.